Northern School of Medicine faculty as a lecturer in 2017. He has actively participated with the medical students, medical residents, nurse practitioners, and PA students clinical teaching during their electives. I actually met him the first night we were here, and he's a very interesting, well-spoken gentleman who actually immigrated to Canada and then became a PA. He is raising 2 kids, a family. They enjoy skiing, winter camping in the summer, and judo all year. Victor?
Hello, everyone. So my name is Victor Lukankin. The last K is often omitted, especially in Thunder Bay because we have a high Finnish population, and Lukanin or Lukanin sounds a lot like a Finnish last name. So that's okay. How do I do this? That's my team. I realized I don't have a picture of me and the surgeons together. So I almost photoshopped my face there, but I didn't. From left to right, it's Dr. Osman, Dr. Mary McDonald, and Dr. Matthew Ingves. Dr. Mary McDonald is my supervising physician, and I'd like to credit her for some of the slides and the pictures here. And she's an amazing teacher, and she taught me everything I know about vascular surgery. On the right side, you can see there's a hospital there. Looks like it's in the middle of nowhere, but there's buildings around. It's about 3-story high. And I don't have my presenter slides, so I can't tell you the capacity. I think it's 395 beds, if I'm not mistaken. So we service an area that's roughly the size of France, from Sault Ste. Marie to Winnipeg border, and technically to the North Pole. So there's a lot of people. Thunder Bay is cool because of all these things here. Apparently, poppy was first adopted as the symbol of remembrance in our city in 1921. Sir Arthur Conan Doyle owned the property. We have a very large Finnish population per capita outside of Finland. We've produced more hockey players per capita than any city in the world. Yeah, people are really serious about hockey. Lots of sunshine. We're the sunniest city in Eastern Canada. Terry Fox, you know him. In 1980, he finished his Marathon of Hope just outside of Thunder Bay. And we have the largest grain storage capacity in North America. So there you go. 24 shoes, all looking very pretty. They represent 24 amputations that happen every week in Ontario. So think about the number. This picture was taken from the Core Health Ontario presentation. We, as the vascular surgery service, get to remove the shoes, and the feet look like this. Just a couple of words about the Core Health Ontario. In 2016, the Cardiac Care Network of Ontario and Ontario Stroke Network became what's known Core Health Ontario, and they're the advisor to the Ministry of Health regarding cardiac, stroke, and vascular care for all Ontarians. There's a busy slide. It basically tells you how many amputations per 100,000. And if you look up where the darkest color is, that's where we are, and it's ridiculously high. We'll talk about the numbers in a bit. So Core Health Ontario identified that 1.53 million people have diabetes in Ontario. Almost quarter of people over 70 are estimated to have peripheral vascular disease. 300,000 people are defined to have high amputation risk in the last 5 years. 1,200 major amputations annually. Major is major joints, so below knee and above knee. We're not talking toes. $70,000 per amputation, 140 million of direct cost. So if we can reduce by the number of amputations by 20%, we can save 240 limbs. Some have the TV here. Oh, and that would save our system 16.8 million in costs. So let's talk about PAD. It's peripheral arterial disease is stenosis or occlusion of aorta or limb arteries, which leads to lack of tissue oxygenation or called ischemia. It can be acute or chronic. Acute is usually embolic, and chronic is usually happens because of the atherosclerosis or hardening of the arteries. Either of these can lead to death of tissues, nerves, muscles, bones, ultimately resulting in amputation. Risk factors. So you can tell that the diabetes and smoking are number 1 and 2, and they're followed closely by hypertension and hyperlipidemia. So let's talk about acute limb. So I put up this slide. I was giving a talk to a room full of young nurses, and I just thought I'd be funny. So I put name John McClane, and there was crickets in the room. I did this. There's more crickets. Only 2 people knew who this guy was. So in case you're wondering, is this guy. So he smokes a lot. He's got hypertension, but otherwise healthy. So let's talk about a case quickly. 58-year-old guy comes to emerge. He's got 4 hours of right foot pain. It woke him up from sleep. The foot is pale. There's no pulses. There's no Doppler signals. He now developed numbness from the mid shin down to the toes and has a motor weakness at the toes and ankle. What are you guys going to do? And you have an option of doing it online, or you can just raise your hands. So aspirin, walk it out, reassess in an hour is A. B, start heparin IV, get a CT scan. C, start heparin IV and get an angiogram. Or D, heparin and take him to the OR. I think it's A. B. C. D. Okay, so keep that in mind. Keep your answer in mind. We'll get back to this case. Did I skip a slide? There you go. So what are the causes for acute limb ischemia? It's usually embolic in nature, where when the blood clot forms somewhere in the body and travels to the limb. It's mostly embolic. It usually comes from the heart. 85% cases, it's a heart clot. 15% could be somewhere else in proximal arteries. Those arteries are usually aneurysmal. So popliteal aneurysm would be a good example. There's also some non-embolic causes like thrombosis, dissection, or trauma. They're fairly rare. It presents as pain. So pain, progressive loss of sensory and motor function, and diminished or absent pulses. This is all very acute. We do like imaging because it helps us to localize the level of occlusion, and we'll have to do a good pulse exam. We'll talk about it in a bit. Acute occlusion is not well tolerated by a patient, and you basically have 4 to 6 hours to make a move. Otherwise, we'll lose the limb. When we transfer patients over from the communities, it's always a life or limb transfer, so they're getting transferred pretty fast. Again, busy slide. I'm going to highlight. Oh, sorry, no, wrong slide. Oh, it's okay. Rutherford classification. You have class 1, 2A, 2B, and 3. Class 1, we'll look at the patient. They're normal. Everything is fine. 2A, there's some sensory impairment, and sensory deficit starts first before the motor. You still have audible Doppler signals, and there's no motor deficits. 2B, they already have sensory deficits. They're now starting to develop some motor deficits, and you lose arterial sounds. The venous sounds will be present because they still use the collaterals to supply the foot, so the veins are still pumping up. And class 3, it's basically a dead-looking foot. It's cold. There's no sensory, there's no sensation. There's dense motor deficits, and you cannot pick up a venous sound. Pulse exam we have to do this on every patient. We start with the abdomen. We try to localize the aorta. Sometimes you can actually palpate the aorta, and you can tell it's wide. We suspect that might be aneurysmal. We check femoral pulse, popliteal, posterior tibial, anterior tibial, and dorsalis pedis, which is formed by the last two. So anterior tibial PT will form DP. Why do we need to do this? By the time I'm done with my history and the exam, I already know where the problem is. It's going to be up the stream proximately to where I couldn't find my pulse. So imaging will just confirm it. We order a CT angiogram. This is not a CT angiogram, it's a tree upside down. This is a CT angiogram. So you can see with the arrow you have, so it's a CT with a dye. So when the dye travels down, it colors everything kind of white. You can see the first arrow, there's an occlusion there. And the bottom arrow basically shows you that there's now no flow into the foot, almost. There's some trickle flow, but very little. What are the options? So these people will need some sort of intervention. We can do an embolectomy. It's, usually it's a bigger vessel where we can actually physically go with the, and I'll show you the next slide, with the catheter, foregrade catheter. We pass it beyond the occlusion, inflate the balloon, and pull the clot out. We can also do thrombolysis, and we do this fairly often. We have a 14-day window. It's not like a stroke. We have 72 hours, I think. 14-day window. We can bring the patient to the interventional radiology suite. We advance the catheter into the leg where the occlusion is, start infusing TPA. They go to ICU. We recheck the next day. We may have to advance the catheter a bit more, and eventually we hope to get rid of the clot. If it doesn't happen, then we think other things we can do, bypasses, which we'll talk about. So the embolectomy, and when I say simple, it's not simple, obviously, but it's fairly simple. You do the cut down, you control your vessel above and proximal and distally, you do transverse arteriotomy, and you advance the foregrade catheter, pull the clot out. And this is the clot Dr. McDonald pulled out from one of our patients who gave us the permission to share this. So they're huge. This is a patient who also gave us his permission to share this. You can see on the left that his foot was densely ischemic, left foot, and after the embolectomy, you can see that the color returned. So he did well. So if we have to go back and think about what are the options. So when you have a patient, so think the patient came, the pain woke him up from sleep, which makes it really acute. He's got pale foot, no palpable pulses, no Doppler signals, and it was numb. So this limb is threatened. When we have patients like this, we often start them on heparin, which also has some dilatory effect. We do need to often see where's the problem. So yes, I'll do my exam. If we take him to the operating room or decide to do a surgery, we need to find bypass targets. We need to see if there's more than one occlusion. So quite often we start him on heparin and get an urgent CT angiogram just to have an understanding of what they look like, and everything else will follow. So in this case, C is reasonable if the CT was done maybe yesterday, but we would start with the CT normally. So in this case, I would get a B here, choose a B. Chronic. So chronic peripheral arterial disease is a little different. It has the same definition as the acute, but the causes are different. So it's usually atherosclerosis or hardening of the arteries, 85%. Some cases might be popliteal aneurysm, Berger's disease, arteritis, popliteal entrapment syndrome, cysts. They're rare. Majority is just atherosclerosis. We have to be mindful that once you have peripheral arterial disease and your feet are affected, other vascular beds are also affected. We're talking cerebrovascular, coronary renal, visceral vessels. So strokes, MIs, chronic kidney disease, bowel ischemia. So all these patients are prone to these. Very quick pathophysiology. You can sort of break it into preclinical and clinical phase, and the clinical phase is building up of a plaque that calcifies and it's that cycle until it basically fills in the vessel, and then it goes into clinical phase. So it has three options. If it's the first one is the mural thrombosis, it can injure the vessel to the point where it ruptures, which is aneurysmal rupture. It can bleed, causing a thrombus, or it can slowly occlude to the point where just no blood flow. We talked about the risk factors on the previous slide. So the big ones are diabetes, cigarette smoking, hypertension, hyperlipidemia, and those are potentially controllable. I circled the cigarette smoking because this is something we encourage for everyone to at least ask the patient every time, what can I do to help you quit smoking today? There's non-modifiable factors. You can change your age, gender, which is questionable now, I guess, family history, and genetic issues. We have to live with those, but we can try to have tight glycemic control, blood pressure control, control the bad habits. ABIs stand for ankle brachial index, and this is something we do in the office. You can do it in the office. Also, ultrasound techs also do them, obviously. To do this, you put a cuff on one of the arms, both arms. You take the highest blood pressure. Make sure the patient is flat for 10 minutes before you do that. And then we put the cuff on the foot, put a Doppler onto a anterior tibial and posterior tibial areas, and you get the pressure, you get the number that way, and you divide lower, so leg by arm. What it gives us, so we assume that the pressure is going to be at least equal. It might be a little bit higher in the feet, just given the gravity, but it shouldn't be less. So what happens if this number goes down? So if the flow is 90% of expected, or 0.9 ABI, you usually won't find the pulse at this point. Do we need to panic? Probably not. There's lots of people walking around without pulses. Some of you might not have pulses, but you're fine. But we can think about the potential beginning of atherosclerotic disease of some kind. If it goes down to 0.7, so 70%, this is where patients might tell you about their intermittent claudication. And it's the cycle of walking, pain in the major muscles, usually calf, thigh, or buttocks, and then they have to rest. The distance will vary. The shorter the claudication, the worse the stenosis is. They usually recover within 10 minutes, 5-10 minutes. So this is claudication. That's called intermittent claudication. If it continues to decline, you have a patient with only half of the expected flow, they will complain about pain at rest. And what happens here, when they walk around, they can't walk very far, but they're okay. And they rely on gravity to pull the blood down into the foot. When they lay down, the gravity is taken out of the equation, and now they have pain. There's one patient population that might skip this step, and those are diabetics. Because of the peripheral neuropathy, we have to be mindful of that. So this is the territory of the critical limb ischemia. We started, and it will progress eventually to tissue loss. ABIs of 0.3 or less, tissue loss, gangrene, and we do need to act. I'm not sure why this slide is here, sorry. Case number 2. So Mr. GM now, 75, he complains of intermittent, reproducible calf pain after walking in Walmart 5 to 10 minutes, or approximately 3 city blocks. Symptoms have been present for 6 months. He managed to quit smoking, good for him, and started walking in the evenings with his friend, this guy. He denies there's no pain in toes at night. There's no tissue loss, and he had no prior revascularizations. What would you do? Aspirin, statin in the walking program, heparin and CT, heparin and angio. So this is an older slide, sorry. Ignore D ABI in the office. So who thinks it's A? B? C? E? Very good. Keep that in mind. We'll talk about it. So not most, a lot of people are going to be symptomatic with intermittent claudication, or rather with chronic peripheral disease. In fact, 20 to 50% might be asymptomatic. Of those who do have symptoms, almost half will experience some sort of atypical leg pain where you can't really pin it down exactly. You may need to investigate things a bit. 10 to 35% will have the classic intermittent claudication symptoms that we looked at before, and only 1 to 2% will go on to have critical limb ischemia, which is the rest pain and or tissue loss. Have to be mindful of differential diagnoses, which are often related to back issues, osteoarthritis. It could be venous claudication, neuropathy, restless leg. So that's why the history is obviously very, very important. This is the grim statistics of the 5-year outcome. So in 5 years, we have the limb morbidity and cardiovascular morbidity and mortality. In terms of the limb, most will be stable. 20 to 30% will develop further claudication, shortening the distance. 1 to 3%, there's data is a little different. 1 to 2, 1 to 3% will have critical limb ischemia. Now the mortality is 10 to 15%. Once you have intermittent claudication, your mortality goes up to 10 to 15%, and 20% of people will die from MI and stroke. It's just a different way of looking at it. It was a summary of 19 studies, and they looked at people. I'll summarize it now. Oh, no, sorry, I do not. So they looked at the 5-year outcomes, and they realized that 1 in 5 will die. Almost half will be alive with both limbs, and 35% will have their limbs amputated. So that's pretty significant. How do we manage these people? Medically and surgically. Risk factor modification, statin at the highest tolerated dose, and some sort of antiplatelet is usually the go-to. In terms of the surgery, we can do open or there's a bypass and endarterectomy or endovascular approach, angioplasty and stent. So medication-wise, we used to prescribe pentoxifylline. It's been shown not to be very effective. We do not take people off it, but we don't start them on it usually. Cilostazol, not available in Canada, so maybe some of my colleagues from US can comment on this. We don't prescribe this, but supervised exercise is really good for these patients. We try to get them on the exercise therapy, which has to be 3 to 5 supervised sessions per week, half an hour to an hour per session. Anything goes, treadmill, track, as long as there's near maximal claudication pain. We try this for 6 months, and we expect the patients to double their walking distance. That's the goal. So once again, so we have 2 treatment goals. We have the limb outcome and the mortality outcome. So for limb, we need to improve their ability to walk, improving their quality of life, and prevent them from going from claudication to critical limb ischemia. That's our one goal. Number 2, we want to decrease mortality from MI and stroke and decrease the non-fatal MI and strokes in our patient population. This is fresh off the press, May 1. Just a couple of slides here. So what they're recommending nowadays is ABIs. It's a weak recommendation, but we can screen asymptomatic adults age 50 or more, asymptomatic. We can use ABIs or TBIs, which is toe brachial index, to diagnose PAD in symptomatic patients, and TBIs for non-compressible vessels. Why do non-compressible vessels happen? Is usually diabetes. They get so calcified that you cannot compress it. You can see it on arterial Doppler. You're trying to compress it, and it's just not happening. Or you put the cuff on the ankle, on the shin rather, and you keep pumping. You're at 200, and you're still hearing everything, so you can't compress the vessel. So we do TBIs. You put on a big toe, you put a probe on, you can actually see the waveforms. Managing risk factors. It's a no-brainer: smoking cessation, tight glycemic control, statin at the maximal tolerated dose, and blood pressure control. And we follow hypertension guidelines, but generally target is less than 140 for systolic. In asymptomatic patients, so antithrombotics, big topic. Everyone asks this question all the time in the hospital. So asymptomatic, we don't do anything routinely. So we don't do this preventively from our standpoint. Could be different from cardiac patients. Now, if you're stable symptomatic, we have an option of aspirin, clopidogrel or Plavix, rivaroxaban or Xarelto. And rivaroxaban and aspirin were part of this COMPASS trial that demonstrated a good efficacy for high-risk limb presentation, high-risk comorbidities. So we can start on aspirin, we can start on Plavix. This is going to be available. It's just a lot to talk about now. I have 40 minutes. Sometimes we talk to cardiology and see if there's some patients might need to be started on dual antiplatelet, and some of them will qualify for that. So there's a lot of back and forth about this. We already talked about that. When do we not sorry. The slides are backwards a little bit here. Indication for intervention for our patients. So claudication, we don't usually. There's exceptions, and I'll show it to you. For critical limb ischemia, which is rest pain, tissue loss, we do intervene. What are the exceptions for claudication? It's lifestyle limiting. So you have a young working adult that cannot function, so we might intervene. But it has to be reasonable likelihood of symptomatic improvement. If we don't think you're going to improve, why bother doing the surgery? We need to talk about other things. Failure of exercise and medical pharmacological therapy, you know, we have to weigh pros and cons. Regardless of what we do, you still have to have smoking cessation, antiplatelet, statin, glycemic hypertension control. That doesn't change. We were supposed to look at the case again. So if I'm going to remind you, so that case was he came to the office. He has intermittent reproducible pain after walking, 6 months, no pain at night, no tissue loss. In this case, it's chronic PD, and it's slowly kind of taking its toll on the patient. He's not taking any medication. It's reasonable to start these people on aspirin, statin, walking program. Not unreasonable to do ABI in the office, but we usually order some sort of formal arterial Doppler or CT. So we'll move on to the third case. So 3 years go by. He's now 78. His friend brings him to the clinic, same guy, because the progressive loss of mobility over the past 4 months. So he used to walk. He was okay. Couldn't walk far, but he could walk. Now the distance is getting shorter and shorter. So he used to be able to walk for 30 minutes, but now complains of severe pain in the left calf after walking to the end of his driveway, which is just 100 meters. And now his left foot wakes him up at night. He's an ex-smoker. He has cardiac disease. He had stents a couple of years ago. He does have hypertension, not on medication still. And his left leg has now dependent rubor. There's still no tissue loss, but also no palpable pulses in either groin or the left leg. What do we do with this guy? Start aspirin, walk it out, check in a few months. Aspirin, statin, and ACE inhibitor. Admit to the hospital and continue workup as an inpatient, or start a heparin and take him to the OR. Who think it's A? B? C? D? Interesting. Okay. So when we decide on the treatment for these patients, we need to think about a few things. Is it acute presentation or is it chronic? Maybe it's acute and chronic. Is the limb threatened? What is the level, extent, and severity of the lesion? So when we look at our patient with a CT or with the exam, we can identify the level of the stenosis whether it's one or multiple, and we need to find a bypass target if we need to go for a bypass, which is the ultimate surgery in this case. And thinking about bypass, we need to have we often talk about the target, and target is a place where you can actually plug it into. And below that point, you have to have direct flow into the foot, because if you don't, and it's an occlusion, the bypass will just stop working. We have a few options here. On the left side, you see surgical, and on the right, endovascular approach. We have endarterectomies, we have bypasses, angioplasty, stents, or hybrid procedures. And let's see if I have the right slides there. There you go. We did talk about embolectomy in the acute setting. Endarterectomy is basically scooping out all the calcium. It usually happens in the groin and the common femoral arteries. You open it up and it looks like a pipe, and you scoop it out and you patch it. Happens often in smokers, not sure why. And it's a fairly straightforward case. If things don't work out and the occlusions are really long, we can't do an angioplasty, we can't stent them, we need the bypass. So we can bypass almost anywhere to anywhere, to be honest. Left to right. So left would be probably common femoral or proximal superficial femoral artery to popliteal. On the middle one is to below the knee. We can do top right. We can do once, we can take blood from one side and give it to the other. It's called femoral bypass. We can even track it all the way from the axillary artery under the skin into the groin and then distribute the blood flow there. It's a major surgery though. We're talking 6 hours, very difficult recovery. Once these, and then keep in mind that they also have other vascular beds involvement. So it's not uncommon for our patients to have a MICE postoperatively and sometimes strokes. How do we follow these patients? We collect interval history. We check patency of the grafts with ABIs. We order formal ultrasounds. We have to be mindful of our resources because we only have a handful of techs up where I am, I think 4, I believe now, that are qualified to do arterial Dopplers. So we have to really pick and choose what we do. We do prophylactic intervention for graft stenosis to promote long-term bypass patency. Bypass lifespan is about 7 years. I've seen people with bypass that's been there for 30 years, and some of them will occlude the next day. Smoking makes it worse. It shortens the lifespan. So if you think about this patient again, he's now developed rubor, which is different from erythema. It's a capillary response to chronic ischemia. If you want to check your patient, you need to elevate the leg 60 degrees up, wait 1 minute, you'll see the blood drain away from the foot. Then you bring it down, and it will color the foot bright red. Erythema doesn't do that. So he now has, he's getting worse. He's not taking any meds. He's got no palpable pulse. He's got rubor. So his limb is now, it's not threatened right this moment, but it's certainly getting there. So in his case, we certainly start the medication. We would probably do an outpatient CT, and it's not unreasonable to admit. And who do we admit? We admit people that come from remote communities because they took 2 or 3 days to travel all the way to Thunder Bay. We're not going to send them back. So we often admit, work them up, and then maybe send them home and bring them back again. So just a quick summary. Asymptomatic patients, we do basically cardiovascular risk factor management, claudication, same, plus the walking program. And we consider revascularization if this is disabling. And for critical limb ischemia, we revascularize. So when do you call the vascular surgeon? Is critical limb ischemia patients, obviously acute limb, or anyone with a wound that hasn't healed in 6 weeks. That's a very, very reasonable vascular surgery consult. And this is just my last slide. It's the case of a person that we've treated. She came with a wet gangrene. I don't have the first slide or the last one. But this is several weeks of wound care, and then she eventually had a split thickness skin graft by our plastic surgery team. and recovered her foot. So that was satisfying. We don't get a lot of satisfying cases, unfortunately. That's it. Any questions, guys? Mhm. Well, all of our patients are systemically vasculopathic. So we, you know, we use veins. So there's different, again, like some of the slides didn't make it to here for some reason, but we use veins. You can use in situ, so the same side, we can harvest it from the other leg or the arms. We've used cadaveric veins, not very successfully, or use synthetic. There's synthetic grafts. There are PTFE and DACRA, different style, different types. The synthetic grafts are more susceptible to infections. You have to be mindful of that. They're designed not, I mean, you know, withstand it, but they can get infected, then they have to be explanted. And we actually have to share the veins with cardiology too. And we're actually mindful of that because we're looking at our patient, and you might need a cabbage. So we gotta be careful with this. Yes. Sorry, I had a hard time hearing you. Are you just commenting that that is correct, and we often get phone calls from Emerge, and there was, you know, we get it's very wide, you know, examination sort of pattern. You know, I feel some pulse or no pulse at all, or a little bit of pulse. Usually, you know, we suggest to undercall it. So if you feel like you may not be sure about it, just say no, and then we can come and assess properly. I agree with ABIs for diagnostic is not for, especially for acute limb. Like you don't need to do this as a primary care provider. If you are one, this is something we will do. You know, you can recognize different sound, like, you know, there's the monophasic, biphasic, triphasic sounds, and you can hear, you can see it on the machine if you have it. I agree, ABIs, in my mind, like, you have to know what you're doing with those usually. So if you're comfortable, do it. If not, probably not. All right, that's it.